Hi, I'm Dr. Ramasubramanian. I'm a consultant in infectious diseases at Apollo Hospitals, Chennai, and I'm also the medical director of the Capstone Multi-Speciality Clinic in Chennai. My topic today is on antimicrobial stewardship. Before we move on to antimicrobial stewardship, we should understand why we need the stewardship. Antibiotics have been wonder drugs. They have been miracles which have saved lives over the past few decades after they have been discovered. But unfortunately, they are falling prey to the tragic irony of antimicrobial resistance. When antibiotics are used, they select out the normal process of mutations in bacteria, which can lead to antibiotic-resistant bugs, and subsequently, the antibiotic becomes useless. In other words, the hunter becomes the hunted. A study done a few years back by Jim O'Neill showed that by the year 2050, almost 10 million people will die due to directly or indirectly effects of antimicrobial resistance. It will also lead to phenomenal expenditure. Over 100 trillion US dollars it is envisaged will be spent in handling this process. How does antibiotic resistance happen? When a high number of bacteria is present at a site of infection, a few of them may be resistant to antibiotics and the rest will be sensitive. When the person is exposed to antibiotics and the bacteria face the antibiotic, most of the susceptible bacteria will die, whereas the resistant bacteria will start multiplying. Now the resistant bacteria may start sharing drug resistance with each other so that in a matter of time, sometimes in a matter of few days, antibiotics will not be effective because most of the bacteria will have resistance to the antibiotic to which they have been exposed. There is something which is called the killing paradox of antibiotics. The more we use them, the more likely we will lose them. A very elegant study looked into the usage of antibiotics and compared the occurrence of resistance and found that those countries, especially the Scandinavian countries which used less of antibiotics, the occurrence of resistance in Streptococcus pneumoniae to penicillin was very, very low. Whereas in certain other countries, mainly Spain and the United States, where there was a high tonnage of use of antibiotics, the resistance in strep pneumoniae to penicillin was very high. This is just a simple study correlating the use of antibiotics with the occurrence of resistance. But what are the principles of antibiotic resistance? Given sufficient time and drug use, resistance will emerge. Resistance is progressive, evolving from low levels to high levels. Organisms which are resistant to one drug are very likely to develop resistance to others. Once resistance appears, it declines slowly, if at all, and most importantly, unlike other medicines, the use of antibiotics in one person affects the entire community. How does this happen? When somebody takes an antibiotic, the antibiotic changes the microbiome in the intestine, for example. So, what is secreted in the fecal matter will be resistant bacteria which are able to survive the antibiotic. If this sewage contaminates either plants or animals or other areas of the community due to poor sanitation and hygiene, the resistant bacteria spreads to other members of the society. So please remember, taking an antihypertensive, an anti-diabetic, or an antipsychotic will only affect the person who is using it. But an antibiotic, even if I take it, the implications can spread to the entire community. To add to the woes, on one side, we are having escalating antibiotic resistance and we are losing out on antibiotics. And on the other hand, we are having a shortage of newly developed antibiotics. If you look at the antibiotics which have been invented, discovered, and produced over time, you will find that there is an antibiotic drought. There are several new antibiotics which were found before the 1980s, but since then, in the last 3 to 4 decades, there have been very few antibiotics classes which have been discovered. So to get over this problem, we need to ensure that we adopt antimicrobial stewardship. What does antimicrobial stewardship mean? The Society for Healthcare Epidemiology of America defines antimicrobial stewardship as coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal antimicrobial drug regimen, dose, duration of therapy, and route of administration. So how do we tackle the crisis of antimicrobial resistance? It is not only through antimicrobial stewardship, we also need diagnostic stewardship and infection prevention stewardship as part of the whole spectrum to ensure that we preserve our antibiotics. The 4 Ds of optimal antimicrobial therapy include the right drug, the right dose, de-escalation, which basically refers to the concept where if the person is empirically started on a broad spectrum antibiotic, once the result is available and we find that the bacteria is more susceptible to a focused narrow spectrum drug, we need to de-escalate from the broad spectrum antibiotic to the narrow spectrum antibiotic. And the 4th D is the right duration. When you look at the implementation of antimicrobial stewardship as a program in a hospital, there are certain core interventions. These may include hospital leadership and commitment, which means that they should dedicate necessary human, financial, and technological resources for the success of the program. We need to make it accountable. So there should be an AMSP leader for managing the program and also a committee or a team which will work with him. There should also be pharmacy or drug expertise. So there need to be a pharmacist who is dedicated to implement the AMSP activities. There should also be key interventions which I shall tell you subsequently. Tracking of antimicrobial usage, prescription, and the impact of interventions or other important outcomes should also be part of the AMSP program. Reporting of the information on antibiotic use and resistance patterns should be made to all the people involved in using the antibiotics and also to the hospital leadership. Lastly, education is a very important part of the AMSP program where periodic updates should be given about antibiotic resistance and the prescription practices. So the important part of the program is the antimicrobial stewardship team. Who are the members? It should include a physician or an infectious disease consultant. The physician should be trained in infectious diseases to lead the program. It can also be an intensivist or a critical care physician. There should be a pharmacist trained in infectious diseases and the correct usage of antibiotics. A clinical microbiologist should be part of the team to ensure the diagnosis of infections is made correctly. A hospital administrator to liaise and ease out the implementations processes, and also an infection control nurse who can monitor the program. If you look at the individual interventions as part of the AMSP program, first is to collection of data, what is called a surveillance, to see what are the bacteria causing the various infections. We also need to do antimicrobial susceptibility testing and put it in form of an antibiogram. Based on the antibiogram, which may be unique to each hospital, you have to develop an antibiotic policy. One has to ensure that the policy is made available to everybody so that they are aware of what antibiotic to use for what infection, disease, or syndrome. There are also certain core interventions. This may include prospective audit and feedback, where the usage of antibiotics are prospectively monitored and the doctors are given a feedback on what they are using and whether it is compliant with the antibiotic policy. There can be either pre-authorization or a formulary restriction where certain high-end antibiotics, the expensive, the big guns, are identified, and if anybody has to use these antibiotics, then they should have pre-authorization by a senior member of the treating team, or you can also put it as a formulary restriction where if they have to use those antibiotics, there is a process by which authority is granted before the person is prescribed and the patient gets the antibiotic. There can also be infection-based interventions whereby you identify syndromes and you give guidelines for antibiotic use based on what syndrome the doctor is treating. There should also be point-of-care interventions to optimize the dose of the antibiotic to ensure de-escalation is carried out, or if one can shift from an intravenous preparation to an oral preparation, that should also be facilitated, and there should be specific indications for that. This is an example of an antibiogram where you see the susceptibility patterns of various bacteria to certain selected antibiotics. Tracking the course of antimicrobial stewardship is also very important. The tracking could either be related to process measures, whereby you monitor the use of antibiotic or antibiotic consumption rate based on daily defined dose or days of therapy, or you can do a point prevalence rate of microbial cultures. You take a 24-hour time period and you look at the number of people who have been given broad-spectrum antibiotics, see how many of them have had appropriate cultures sent off before starting the antibiotic. This will give an idea whether people are compliant with the diagnostic stewardship before antibiotics are used. It is important to also track outcome measures. These may include the occurrence of antimicrobial resistance before and after intervention, the average length of stay of a patient before the initiation of the stewardship program, and then how it fares after that, mortality and readmission also. And please remember, education is a very important part. A periodic update on how antibiotics are used, how we can use them better should also be done. But when we come to practical aspects of antimicrobial stewardship, we should align them to what is feasible and what can be effective in India. We need to innovate. So this may include limiting surgical prophylaxis to less than 24 hours, avoiding prophylactic antibiotics, ensure that cultures are sent off before starting broad-spectrum parenteral antibiotics, encourage accurate diagnosis rather than empiric antibiotics in a person who is hospitalized and develops a fever, avoid empiric antibiotics for fever in a patient who is hemodynamically stable, ensure that antibiotic therapy based on the local hospital guidelines, get the dose of the antibiotic right, avoid routine use of combination therapy, and learn to de-escalate when it is feasible, especially when culture results are available. Tackling antimicrobial resistance is an uphill task. It is akin to what you see in this picture. But I think with discipline, awareness, and education, we can definitely overcome the hurdle and make sure that we use our antibiotics right. Thank you.